Good evening and welcome all to our webinar series brought to you by the Mount Sinai Hospital, Marie, Josie, and Henry R. Kravis Center on 85th Street. I am your host, Frank Vera, and along with me as panelists will be Janet Johnson, DNP, who is the clinical director of our center, and Marnie Friedman, our registered dietitian. As our guest speaker, we will have our very own Dr. Jeffrey Mechanick lead tonight's discussion titled Diabetes Update. Diabetes is a common disease with common misconception. Tonight, we will explore how it is diagnosed, managed, as well as reducing your risk of developing diabetes. Dr. Jeffrey Mechanick is the medical director of the Marie, Josie, and Henry R. Kravis Center for Cardiovascular Health at Mount Sinai Heart, director of Metabolic Support Divisions of Cardiology and Endocrinology, Diabetes and Bone Disease at the Icahn School of Medicine at Mount Sinai. He is an expert in nutrition and past president of the American Board of Physician Nutrition Specialists. Before we begin, I'd like to remind everyone that if you have a question, please type it in the question box so that we can answer it during the presentation. At the end of tonight's webinar, please take some time to fill out our survey for any feedback or questions we cannot get to. So without further ado, Dr. Mechanick, the room's yours.
Great, thanks, Frank, and thanks, Janet and Marnie. And thanks everybody for attending. We have an hour, and what I'd like to do is sort of go over what diabetes is now in 2021, soon to be 2022, and break it into two questions. The first question is, what is diabetes? And the second question is, how do you manage diabetes? So if we start with what is diabetes, there's a little bit of a historical context. First of all, it's been around and human beings have known about diabetes for thousands of years, probably beginning the first description was in an Egyptian written document where it was described. And it was based on the hallmark features of urinating a lot, being very thirsty, drinking a lot of fluids, being hungry, eating a lot, but also losing weight, being sick, not really doing well. And if you fast forward to the days of Charlemagne, the soldiers on the horses, if they were getting weak and tired, the generals would taste their urine, and if it was sweet, right, and that's where you got diabetes mellitus from. If it was sweet, they would make a diagnosis and treat with French lilac, which was actually the active chemicals are in metformin, which is the mainstay of treatment now. So it's been around, having these high blood sugars in the body. Originally, if you go back to before the 1920s, before the discovery and the manufacturing of insulin, it was a disease of children, very young children, where they failed to make insulin. It was just called diabetes mellitus back then. Insulin was saving everybody's life. Prior to that, it was treated just with severe semi-starvation. You would starve these babies and they could potentially live into maybe the second decade of life. With insulin that could extend life, it was transformative. And it was only until maybe there were changes in culture and lifestyle and more processed foods and carbohydrates. There are a lot of graphs that correlate more baked goods, farming and agriculture and obesity. And as body weights went up, then adults were developing hyperglycemia without having had a history of what we knew to be diabetes on insulin before. So they called this new type, type 2, or adult onset diabetes. And then the first type was therefore type 1 or juvenile onset. What we now have are different types of diabetes with high blood sugar. Type 1 means that you're not really making enough insulin in the body. Typically, this is due to antibodies against the pancreas, against the cells in the pancreas that make insulin, a particular hormone. The pancreas does a lot of things. It makes digestive enzymes and it makes other hormones, but insulin is made by the beta cells in the pancreas. And when you have antibodies against it, which can be induced by various viruses, one of them is rubella, for instance. It's part of a rubella syndrome. And children can then develop, or young adults, teens, can develop this type 1 picture, and it's only treated with insulin. And for those listening who may have type 1 diabetes or have a family member or a friend, we're hoping that down in the future, there will be some type of a cure that can affect the regeneration of cells that make insulin in the pancreas, or can affect the immunology that was hurting the pancreas. Type 2 diabetes is different though. And type 2 diabetes is 90 to 95% of all patients with diabetes. The reason why there's a little bit of a range is there are some patients who have atypical diabetes. It's not typically type 2. It kind of looks like type 1. It may present in adulthood, and it's a little bit of a gray area. But for the purpose of tonight, we're going to speak about diabetes in terms of the most prevalent, the most common form, which is type 2 diabetes. So to answer the question, what is type 2 diabetes? There's going to be two answers. The first answer is going to be the old-fashioned answer. And the old-fashioned answer is it's a disease where you have high blood sugar, there's maybe some insulin resistance, and you treat it by trying to get the blood sugar in a normal range. You use as much medicine as you can to get the blood sugar in the normal range. Of course, there's lifestyle. You need to eat right and avoid sweets and avoid eating a lot of carbohydrates. Try to keep your weight controlled. But that's pretty much it for type 2 diabetes. Exercise is good, but for the most part, at least in this country, it's treated with medicine. Medicine to get the sugars in the right range, medicine to get the A1C or the hemoglobin A1C, which is a sugar-coated molecule in the blood, hemoglobin, that is in proportion to sort of what your average blood sugar would be. And it's all about numbers. That was the old-fashioned way. The new-fashioned way, the way we do it now, is a more comprehensive approach, and it's within the context of managing complications, of which the most important is cardiovascular. Cardiovascular disease is the #1 killer around the world. So that's the context of diabetes. And diabetes is a driver, a cause. It's one of the main mechanisms by which a lot of people will get cardiovascular disease or heart disease, hardening of the arteries, heart attacks. So here's how the story goes. You're born and you have genetic predisposition, but you also live in a certain environment. And that environment could be on a farm where maybe you're eating very healthy, or it could be in the city, it could be in New York where you're passing a Dunkin' Donuts every day and you're not eating that healthy, but there's an environment. And the built environment is that part of the environment that's made by humans. So it's really the built environment that's playing a role. And then the interaction of genetics and the environment gives rise to a human behavior. And that human behavior dictates whether you're going to buy that donut or not buy the donut, whether you're going to overeat or not overeat. And if you overeat, you're going to put on more fat on the body than you need. So if there's a very strong genetic predisposition for insulin not to work well, then it doesn't matter what the environment or the behavior is. But if the genetic component is sort of the average genetic component, there are many, many genes that control the way insulin works, then environment and behavior really do play a major role. And that controls your lifestyle. And you may be eating more than you should, more than you're burning, or not exercising enough, so you're not burning as much. And now fat accumulates on the body. And if we move through the next chapter of the book, as the fat accumulates in the body, the fat accumulates not just under the skin, where you tend to think you have fat, maybe in the belly, in your legs, in your butt, but also in your organs. Fat can be in your liver. Fat can be in your kidneys. Fat can be in the pancreas and actually affect the way it makes insulin. It can be in the bone marrow a lot more. It can actually get in your muscles, but fat can also get around the heart. And when the fat gets around the heart, it starts to have very bad effects on atherosclerosis or hardening of the arteries. It can have bad effects on the heart muscle, the way the muscle contracts, and that can lead to heart failure. And it can have effects on the electrical system of the heart, what gives you those contractions, the rhythm, the rhythmic contractions. It can give you irregular heartbeat, like atrial fibrillation. So obesity is really a type of abnormal fat in the body. And it's not just by virtue of your body weight. We tend to think, oh, when your body weight reaches a certain amount, your body mass index crosses a certain threshold, and then you're defined as overweight, and then you're defined as obesity and different types of obesity. But really, once you start on that path of an unhealthy lifestyle, you're having abnormal fat in the organs of your body. It's a little scary. And maybe that could even be a motivator to try to change your lifestyle. Now, the next chapter. Chapter 3, all of this extra fat shouldn't be there. It's abnormal. The body doesn't like it. It causes inflammation. It gives rise to abnormal fat molecules circulating in the blood called lipoproteins, or LDL, HDL, cholesterol, triglycerides, and these lead to heart disease, causes inflammation, so insulin doesn't work, or insulin resistance. So now imagine a situation where you eat a meal, sugar goes up, your pancreas, the beta cells make insulin, but the insulin doesn't work. Sugars are still high. Now the pancreas has to work harder. It has to make more insulin. So insulin resistance is not necessarily about the insulin not working. It's actually about walking around, living your life with very high insulin levels. And those high insulin levels prevent you from burning off the fat. And that's why it's so hard to lose weight when you have insulin resistance. This has been actually a topic of great debate over the last few decades, because there was one school of thought of a calorie is a calorie is a calorie. You just need to balance the calories, and that's all there is. And now we've learned that really there's abnormal metabolism and insulin resistance, and the type of foods that you consume, the amount of inflammation in the body is very important. So the next chapter is this poor beta cell is trying to crank out all of this insulin to overcome the insulin resistance, and eventually it burns out like a little car. You're flooring it to go up a big mountain, and you see smoke coming out of the engine, and the gears are getting stripped, and all of a sudden you're not moving forward anymore. It can't make enough insulin, and now the sugars go up. Now you go to the doctor, and the doctor, when they draw blood, says, oh, your sugars are up. You have diabetes. But for the last 10, 20 years, this process has already been in play. And that's why the answer is different than the answer I gave before. The first answer was you wait and wait and wait. You get diabetes, your sugars are high, take medicine, normalize the sugar, and that's the whole story. Very thin book, a pamphlet. But really the story is unhealthy lifestyle from genetics, environment, and behavior, insulin resistance, beta cell problem in the pancreas. Now sugars go up. And the last chapter, by virtue of the high insulin and the insulin resistance and the inflammation, and by virtue of the high blood sugars, now you get vascular disease, disease of blood vessels. The small blood vessels, like in the eye, in the kidney, around the nerves, those small blood vessels, or micro, meaning small, microvascular disease, that's due to the high blood sugar. But the larger blood vessels, the aorta, the big blood vessel in the middle of your body, and big vessels that are running down your legs, peripheral arteries, and vessels in your neck, the carotids going into the brain, and the vessels that provide blood to your heart muscle, the coronary arteries, Those are large vessels. That's macro, meaning large macrovascular disease. That is primarily affected not by the high sugar, but by the high insulin levels and the insulin resistance and the inflammation on the cells of those blood vessels. So it's a very complex pathophysiology, a word that means mechanisms of disease, which we now understand a lot better. Certainly, we have a lot of different medicines that can address it, but the one intervention that addresses all of this at the root cause is actually lifestyle change. And lifestyle change is not a casual, I'm going to be on a diet and eat a little bit less. I'm going to try keto. I'm going to try intermittent fasting. I'm going to do South Beach or Atkins or Zone or any of these things. It's really a commitment for life. So the same commitment that was made to eat those donuts every day and work on Wall Street and sit in a chair or drive a vehicle and you're not moving, that's a lifestyle that could last your whole life. We would like you to adopt a lifestyle that's healthier with movement, with eating healthy, and believe it or not, all of these mechanisms can actually reverse. The heart disease can reverse a lot of the disease in the brain that could lead to dementia, the disease in the kidneys that could lead to dialysis. This can all reverse. So the two questions for today: what is diabetes? The old answer, just sugar up. The new answer, a larger story with lots of different organs and preventing the progression from insulin resistance to hyperglycemia, high blood sugar, to complications like heart attacks. That's the new answer. The second question, how do you manage it? The old answer, you wait. All of a sudden the sugar's high. You may even wait then. And now you don't feel well. You're urinating a lot. You're losing weight. You don't feel, you're tired. You have a heart attack and then it's picked up, or a stroke. And then you treat with a lot of medicine and surgery and procedures. Old way. New way, you start to see and detect an unhealthy lifestyle, even before the weight goes up. Very early prevention. Or weight's going up, let's get that weight down before we get insulin resistance. Or we see signs of insulin resistance. We can measure insulin levels and they're higher. We can do a body composition, the bioelectrical impedance scale that's in the Kravis Center on 85th Street or on 1 West. And we start to see too much percentage fat. Now we intervene before the sugars go up. Or fine, you waited too long. Now the sugars are going up a little bit. You have pre-diabetes. They go up a little bit more, diabetes, but you still intervene before you get the complications. It's all about preventing the progression of disease. Let me conclude by going through 3 types of interventions, prevention or treatment, for type 2 diabetes. The first is lifestyle. Lifestyle would be healthy eating, and Marnie will speak a little bit about that. Proper physical activity, which is aerobic, being on the treadmill or the bicycle, moving, breathing, or with weights for progressive resistance training and strength training, because the muscle can take up glucose and lower the blood sugar, even independent of insulin, but also behavior, healthy behaviors, wearable technologies, pedometers, and continuous glucose monitors, healthy behaviors to reduce stress, healthy sleep, of course, not smoking, a risk factor for atherosclerosis, alcohol moderation, or not drinking alcohol, not abusing substances, and really just learning how to be happy, being involved with the community, a way to be happy and fulfilled and live a healthier life. That's lifestyle. Second, the medicines. The first line therapy typically is metformin, but in the setting of risk for heart disease or having heart disease, there are now diabetes medicines that prevent heart disease. They also prevent kidney disease. And those are the medicines that are the SGLT2s. It's a classic, it's very technical, or the gliflozins, so Jardiance or Farxiga or Invokana. Those are the ones that can help prevent some of the heart disease and the kidney disease. The injections, or the GLP-1s, glucagon-like peptide 1 receptor agonist. Those are those injections, either once a day, used to be Byetta or Victoza, Saxenda to lose weight, or once a week, Trulicity or Ozempic, and now for weight loss, high-dose Ozempic, which is semaglutide, which is called Wegovy. And maybe Janet can speak a little bit about some of the issues and the logistics in getting those medicines. There are other medicines that are used like insulin and like the sulfonylureas like Amaryl or glipizide, but we try to stay away from those medicines as much as possible because you gain weight, they stimulate appetite, they can make your sugar go too low, and believe it or not, they can lead to an increased risk for heart disease. Those are your medicines. Then you move on to procedures. For diabetes, bariatric surgery procedures can really lead to remission of diabetes, but patients really need to be selected correctly. If you have somebody who is overweight or obese or severely obese, and they have diabetes out of control, not responding at all to lifestyle or medicine, yes, we're going to start thinking about appropriate use of these bariatric procedures. Many of them are surgical. You've heard of them, the sleeve or the bypass. And many of them also are not surgical. There's a balloon, and there are other procedures that are done endoscopically, the way you may have upper endoscopy with your GI doctor. But they're not used that often in the management of diabetes, particularly now with the medicines working so well. So with that, let me pause and I'll turn it back over to you, Frank, to maybe ask Marnie to comment about nutrition, or you can comment about physical activity, or Janet can talk more about the monitors and the CGMs and a lot of the new technology that's available with pumps and with the Libres and with the Dexcoms. And I'm obviously here and available to comment as well.
Thank you, Dr. Mechanick. I'd like to remind everybody, if there's anything that you heard up until now that you'd like Dr. Mechanick to clarify, or one of us to clarify, please type it in the box below and we'll answer it as we go. But to carry on with what Dr. Mechanick was talking about with lifestyle interventions and exercise, we recommend that all patients with diabetes exercise at least 3 days a week. Now, I know if it's difficult for some people to achieve this, but getting any type of physical activity during your day is very important. It doesn't have to be too structured when you start out this program, but taking longer walks throughout your day, finding stairs to take instead of the elevator, planning your commute to work, maybe to have a bus stop a little bit further away from work to get in those extra steps can help. In fact, anything that is better than nothing can help you improve your daily activity and your energy expenditure. When it comes to structuring your exercise more routinely, or having more structure to it, you do want to incorporate different types of exercise. And like Dr. Mechanick mentioned, aerobic exercises are those exercises that are long in duration, that last anywhere between 30 to 45 minutes, sustaining your heart rate and doing a repeated motion over and over again. Something like walking, bicycling, swimming, jogging, and sometimes even dancing can be activities considered to be aerobic exercise, meaning you're using your oxygen. You want to combine those exercises with resistance training. Now, resistance training is lifting weights, training the muscles specifically for strength improvements, for muscle size improvements. Now, resistance training, there are many, many different modes and ways that you can achieve this. It doesn't have to be the traditional weightlifting of big dumbbells or being in a gym, But doing something as simple as moving your body up and down from a seated to standing position recruits large muscle groups that can improve through repeated motions their strength and their muscle size, which can eventually improve, like Dr. Mechanick was talking about, the uptake in glucose that is circulating in your body. You can become a little bit more insulin sensitive to the insulin and allow the glucose to be absorbed through your muscles. Resistance training is very key for those with diabetes, and we want to be able to train large muscle groups. And those larger muscle groups are the chest muscle, the back muscle, the leg muscles, and complete movement patterns that require multiple limbs, meaning body parts that are moving at the same time. For instance, like I mentioned earlier, a sitting position to a standing position. Your knees, your hips, your ankles, and a little bit of your lower back are all moving at the same time. Another exercise that would incorporate multiple limbs moving at the same time would be a wall push-up or a traditional push-up from the floor. So when you envision this action, your hands, your wrists, your elbows, your shoulders, your chest, all of those movement patterns are occurring at the same time, recruiting larger muscle groups. So resistance training along with aerobic training are two very important key elements that we want to incorporate into daily exercise. We want to try to achieve 150 minutes a week at minimum to receive the health benefits of exercise. But if weight loss is something that you're trying to achieve, then you want to achieve longer times, maybe 200 to 300 minutes a week of exercise. And like I mentioned before, you don't have to start out at 300 minutes right away, but start off small and make realistic goals for yourself to achieve something that can accumulate to those times by the end of the week. And the key term there is accumulating the time. You want it to add up. Now, I know some people are probably thinking, well, what if I can do all my 90 minutes or 150 minutes in one day? Well, that's great, but that's not a very smart approach to your exercise. In fact, anything longer than 60 minutes of continuous exercise doesn't really show any added benefit to what you've already done between you starting and achieving 60 minutes. So think of smaller bouts of exercise that are more attainable and easy to complete throughout the day, that you can attain on multiple days during the week so that you can achieve your 150 minutes, your 200 minutes, or your 300 minutes a week. If there's any questions to anything that I just mentioned right now, again, please feel free to add it to the text box below and we'll try and get to it. Now, along with the exercise, of course, comes the lifestyle intervention of healthy eating. Now, we always incorporate a heart healthy diet with trying to manage diabetes. So Jana, I'm so sorry, Marnie, if you want to add on to anything that I've mentioned and what we usually tell patients to try and eat for a heart healthy diet or diabetes.
Definitely. Thanks, Frank. So with diabetes, we're looking for a plant-based diet, but plants that are going to be in general, your non-starchy vegetables. So we want pretty much any vegetables besides peas, carrots, and peas, corn, and potatoes are going to be good vegetables. So things like broccoli, asparagus, lettuce, spinach, whatever it may be that you like. We want to include mostly vegetables in our diet. Additionally, it's going to be low glycemic index foods. So foods that aren't going to raise your blood sugars as much as the higher glycemic index foods. So these are things like, beans and lentils, or green apples, or, berries, things like that are going to maintain a more stable blood sugar. Additionally, we want to choose lean sources of protein. So chicken, fish, turkey, eggs, beans, those are all good sources of lean protein, preferably though without the skin and not fried, just grilled or baked as much as possible. If we are going to have carbohydrates, it's very limited. We do want to, again, try and choose lower glycemic index carbohydrates. And then for beverages, avoiding juices, sodas, things like that, and choosing water as much as possible.
Okay, Marnie, so questions that I get, so you're talking, so can you go a little bit more like what's a good carbohydrate versus not so good carbohydrate?
Definitely. So we want to avoid carbohydrates like breads, pastas, pretty much any of the refined carbohydrates that are processed, and choosing things like beans and lentils that are carbohydrates, but they have a lot of fiber and added benefit for that for us, and avoiding juices, avoiding actually excessive fruit, which is also going to raise blood sugars more than some of the other carbohydrates.
Okay. And another question that I frequently get, if they have to have a healthy snack, say at the, before they go to bed, because maybe they were having some low sugars during the night.
Mm-hmm.
So what is a healthy snack? What for a person with diabetes?
Okay. Yeah. So we want, in general, when we're thinking snacks, we want to try and pair it with either a protein or a healthy fat. So say, for example, you are having, like an apple or something. If you put a little bit of peanut butter or almond butter, ideally on it, it will help to stabilize the blood sugars more than, if you just ate that apple alone. But you can do things like berries or, green apples. Those are good fruit options for patients.
Okay. I'd like to talk a little bit about what is available for glucose monitoring. The staple for people with diabetes and monitoring their sugars at home were finger sticks. And there's multiple number of, glucose monitors out there. But what problems that I've seen patients run into is a little bit of adherence. It's after a period of time, and even early on, one's finger gets sore from doing this. People that are on insulin 3 or 4 times a day should check their sugars before every meal in order to make sure that insulin dosing is correct. Now, but people on oral medications sometimes drift away from those checking and only do it first thing in the morning. And what's the problem with that? If someone comes in and says, okay, my blood sugar has been 100 to 120 every morning, but when we check their lab work, their hemoglobin A1C, which is the measure of the blood glucose of 2 to 3 months, is a high number. A normal number of A1C is between 6.5 and 7. That's our goal. But here at Kravis, we like to have the patients closer to 6.5. Did I say, yeah, 6.5 and 7? We like them closer to 6.5. And so a patient will come in, say my morning glucoses are 120, but the A1C is 8. So where's the disconnect? And what happens during the course of the day is after whatever they have for breakfast or lunch or dinner, the sugars go up and they're not aware of it. So what has recently come out really in the past, I don't know, Dr. Mechanick, maybe you can say maybe about 5 to 6 years, maybe a little bit longer than that, FDA has approved various continuous glucose monitors. There's 4 of them on the market, but we basically use 2 of them. And one of them is a Dexcom, which is a real-time glucose monitor where the patient wears a monitor. It's and a transmitter that's placed on the abdomen, and they can use a receiver or a phone and get continuous readings. The update, I believe, is every 5 minutes. And alarms can be set, and they can see how their daily activities, their food, their exercise affects their blood sugar. So not only does the physician get a more detailed look at what their glucose is throughout the not only 24, but we can do a whole week, we can do a whole month report. But I find the patients then find out really what is going on with their diabetes. So that's the one monitor. And the other type of monitor, it's called a Libre, Freestyle Libre. And this is an intermittent scanning or flash scanning. And it is also a sensor, but this one is placed on the back of the arm. And both of these devices are very simple to learn how to use. And the patient has to actively scan the sensor in order to see what the glucoses are. So if they scan every 3 to 4 hours, then they're able to get a very good picture also of what their glucose is. Now, originally, these were just used for type 1 diabetics or for type 2 diabetics who were on insulin several times a day. And that's what the initial studies came out. And they found that there was improvement in their A1C, plus improvement in the quality of life. And why is that, you ask? But there's several reasons. Obviously, they didn't have to stick their fingers a couple of times a day. They knew what's going on with their diabetes. They could control it. They could make changes. It's a really empowering tool. So at this point, Medicare and most insurances will only pay for the systems if you're on insulin 3 or 4 times a day. Here at Kravis, we've used this as in many patients who are on oral medications or maybe just one injectable. And the price has to, a patient has to be able, we make them aware of what the monthly price is. But if it is able to be affordable within one's budget, we really find the patients, it is a very empowering tool to them. They can help to manage their own care and be a more active participant in their overall health. So this is if you have one, then you can attest to how it is working within your life. If you don't, and if you're interested, talk to your endocrinologist or your primary care physician about seeing one of these. We have also some older patients who are being cared by a family member or a nurse's aide at home, and they're able to test the sugar and help to manage this patient again at home and keep them within a certain goal that we've set. So what has come out of this is that, and what will soon be or if not already, the gold standard, instead of the hemoglobin A1C and all the physicians and patients looking at that to see whether they're control, they're going to be looking at something known as time in target. So both of these devices will give us information how much time within either a day or within a week or within a 30-day period the patient is within a certain target range of 70 to 180. And if the patient is within 70% of the time within that target, that is considered control. So it will be soon to come. Everything I hear and read recently always goes to that discussion. So if you're interested, you should be discussing this with your physician for your care or your family's care.
Thank you, Janet. A lot of information there. In fact, you bring up a couple of points that reminds me with daily monitoring of your blood sugar is the importance of monitoring your blood sugar before you begin your exercise. And I know a lot of patients who begin this don't have the thought process to see, well, let me see what my blood sugar is before I exercise. And the reason for that is because exercise can, in fact, reduce your blood sugar while you're doing vigorous activity or long aerobic exercises. So you want to be sure that your blood sugar is within a safe range, that it won't drop drastically during your exercise. The number that we do try and shoot for is a blood sugar level of 90 or above to begin your exercise. Now, it is probably a smart idea to be checking that periodically during your exercise if it's something new that you've started as part of your routine. Try and see what your sugar does throughout your exercise routines to get a better idea of how your body is managing your blood sugar levels. Now, if you do find yourself below 90, it is recommended that you have a healthy snack. And like Marnie talked about earlier today, having a healthy snack, you want to consider trying to stay away from things that could be acidic. Because as you exercise and you get the blood flowing and your body starts going up and down, things can just start making you burp or have acid reflux. And you don't want to have acidic foods in your belly while you're eating. It's just generally not good practice for nutrition for your exercise in general. So this leads into a question that we just got in during Janet's talk. Is cheese a good source of nutrition for protein or carbohydrates? And Marnie, I'll let you take that one.
I can take it. So cheese and dairy products in general are going to have both carbohydrates and protein, but we want to be careful because cheese and dairy products are going to be high in fat as well. So we want to make sure that we're limiting the amount of cheese we're eating, and particularly choosing low fat or skim cheeses, skim milk or cheeses. Because again, for heart health, it's important. And as Dr. Mechanick had mentioned earlier, heart health and diabetes are directly correlated.
Thank you. Now, we do have time from time to time, patients who do begin the exercise routine start seeing changes in their blood sugar levels. In fact, sometimes we do see a drastic increase in blood sugar levels. In fact, it's not recommended if your blood sugar is already at 200 to begin an exercise routine, because exercise can in fact increase that blood sugar a little bit more. And it's a difficult concept to understand. And I'm wondering if maybe Dr. Mechanick can help maybe talk a little bit about why that happens when in fact exercise should be lowering our blood sugar. Why does it increase even more?
It's a good question, and we actually get a lot of patients who become alarmed. They'll epic message us on my chart that they exercised, and instead of it going down, it went up. So it has to do a lot with physiology and the autonomic nervous system and activation of adrenaline and other hormones and factors that work against the effect of insulin. So if you think about the stress response, during the stress response, there are certain hormones that are made that actually release sugar from certain places in the body. The body can actually make sugar. And also it can, during the stress response, there is a relative amount of insulin resistance, specifically so that the sugar goes up and stays up and is available for the brain to use. The brain is consuming vast amounts of sugar, and under stress, the survival is oriented toward protecting the brain. And you want to make sure that you have a rapid delivery system of readily available sugar to muscles to run away from the lion or tiger or bear that's chasing you. So in some people, you'll see that sugar go up. Usually it's with the beginning part while you're trying to get fit. It's not a marker of fitness. It's more a marker of not being well trained and being deconditioned, that you start to see the sugars go up. And over time, what will happen is you won't see as much of a response. The analogy is that if you take the pulse or the heart rate of somebody who runs marathons, you have a slow heart rate. If you look at the heart rate as somebody exercises, then it speeds up very nicely, and then it can settle down and reach a plateau. But if somebody's deconditioned, it can be all over the place, because the circuitry that manages the response to stress and exercise and all of this activity, it's not really trained. And that's the reason why sometimes you'll see that the sugar goes up with exercise. I think Frank brought up the point, and it's actually part of our protocols in the cardiac rehab center in Kravis, that there's diligent monitoring of the blood sugar, not only before, but blood sugars during and blood sugars afterwards, so that we can not only make sure that somebody doesn't have low blood sugars and gets into trouble with exercise. Perhaps they didn't eat coming in, perhaps they didn't take the right dose of insulin, or their medicine wasn't adjusted appropriately. But also it's very informative for you to learn about your body and know what's going on. And now we'll actually loop back to what Janet was talking about. This is the advantage of having these continuous glucose monitors, because rather than the old days where you would exercise, stop, check your sugar, you're actually having a tracing of exactly what's going on. So you can see what's happening in your body, and you can optimize the type of nutrition that you consume before, during, and afterwards in terms of exercise and glycemic index and whole grains and rapidly available glucose and slower release fibers that will contribute to energy over a longer period of time. So hopefully that answers the question to some extent.
So let me pose another question to you, Dr. Mechanick. So this is one I frequently get. So a patient will say that they, when they went to bed, their blood sugar is like 130. They get up in the morning and the blood sugar's 200. They didn't eat anything all night. Why does it go up? They took their medications. Why does it go up?
Right. So this is a classic boards question for endocrinologists, and frankly, it's probably on internal medicine boards, which is what we call the differential diagnosis, or what are the different reasons why somebody who otherwise was controlled but wakes up in the morning and their sugars are high. Let's remove from the equation that they didn't take their medicine, right? That could be one thing, that they just failed to take the insulin or their medicine the day or the night before, and that's why it's high. Let's also remove from the equation somebody who went out and partied all night and just ate a lot of food and was injudicious with their selection of nutrition that night before, and that's why they woke up. And let's also remove from the equation somebody who's sick and actually might have an infection or there's something else going on. And by the way, each of those three things that we're removing, those are questions we're going to ask when we're interacting with patients. We're going to ask them about the way they were eating, their activity. Did you take your medicine? It's actually a big problem in this country that patients in general don't take their medicine. A lot of us just don't take our medicine the way it's prescribed, but let's remove that. What are the physiologic reasons, the reasons that can be explained based on how our body works? And the answer is one of two. One is called a Somogy phenomenon. It's a strange word, S-O-M-O, G-Y-I, Somogy. And what happens there is somebody who's on insulin, they actually take a little bit too much insulin at night. They drop their sugar too low in the middle of the night, or really early morning, like 3 in the morning, 2 in the morning, something like that. And then the body has to jerk and respond with a high blood sugar as all of those counter-regulatory adrenaline-like hormones kick in to prevent hypoglycemia from killing you. They kick in and the adrenaline drives the sugar up, and then you wake up and your sugar's high. Easy to diagnose. You just check a sugar at 2 in the morning. In the old days, we would have you set your alarm. Nowadays, you just look at your Libre or your Dexcom, and you can see if you're dropping too much in the middle of the night, in which case you lower your dose of your evening insulin. The second, which is more common, is called the dawn phenomenon, like dusk to dawn, D-A-W-N. And that's because if you look at mammals, if you ever went hiking or you were in the wilderness and you woke up early, like 5 in the morning, and you look outside in the woods, in the forest, you see all the animals scurrying about, hunting and gathering and eating and chasing and running around and doing other things. And that's because all their hormones are surging. And as a human being, our hormones, from our brain to our pituitary gland, they actually surge at around 5 in the morning. And that's when you're more alert also. So another little tip, if you're working on a project and you're thinking of doing an all-nighter, it's best to just go to sleep and wake up early. Set your alarm to wake up at 3:30, 4:30 in the morning, and you will be able to get the whole project done in probably a half an hour to an hour. Your brain is so alert. In fact, your vision, you have more visual acuity in discerning different shades. And this has all been studied of green, for instance. That's why vegetation is perceived as green to us in our brain. I mean, it's just a chemical out in real life without human beings. But to the human brain, we can actually discern different shades. Our brain is so much more active in the early morning, and the sugar tends to go up. That's the dawn phenomenon. In some people, it's more amplified and the sugar's higher. 200, that is a combination of a lot of different things. It's probably more dietary indiscretion coupled with the dawn phenomenon. Dawn phenomenon usually doesn't drive it up that high. And as we're on the topic, let me talk about alcohol, because some of you are thinking about, I was partying, so I was drinking a lot of alcohol, and that must be why my sugar went up. Not necessarily. Alcohol, just the molecule alcohol, actually lowers your blood sugar. It actually causes hypoglycemia. So if you have diabetes and you drink alcohol, you could actually wake up in the morning with a low sugar, and if you're on medicine, a too low of a sugar. What makes your sugar go up by consuming too much alcohol are two things. One, it's the other stuff that's in the alcohol. If you're having, Cosmo, or you're having some other cocktails and you're having a screwdriver with orange juice, your sugar is going to go up. But the second thing is alcohol not only has calories, but it has calories biochemically in a form that as human beings, we cannot burn off as energy. Using enzymes like alcohol dehydrogenase, we can convert the alcohol to fatty acids, store it as fat, and then burn off that fat, which tends to be a little bit more insulin resistant. So it contributes to obesity. And a lot of patients will come in and they'll have a little bit of a belly and don't understand, I don't eat anything. You should see what I eat. I eat nothing. But they have 2-3 glasses of white wine a day and with cheese. So Marnie, you can go back and address that. But that's the problem with alcohol. And any of you who are patients and you hear us speak in the center, there was a big study by the UK, United Kingdom, the Global Burden of Disease Group, attempting to answer the question, what is the most amount of alcohol a man or a woman can consume without any health hazard, without any adverse effect on risk for chronic disease or hazard to our health? And the answer is not 2 drinks a day for a man, 1 drink a day for a woman. The answer is 0, 0.000, nil, complete abstinence. Any amount of alcohol, and this is the way their abstract ends. The last sentence of the abstract of the paper, published in, I think it was Lancet, in I think 2018 or so, that there is no amount of alcohol that is safe for a human being. Now, obviously, we all may have a little bit. We use it judiciously. We use it as part of celebration. And when it's part of an overall eating pattern, an eating pattern that is primarily, as Marnie said, plant-based. So it's lots of legumes, 2 servings a day of beans, lentils, peas, legumes, nuts, having healthy fats, monounsaturated fatty acids, omega-3 polyunsaturated fatty acids, healthy carbs, which would be fiber, and low glycemic index foods, and lean proteins, then yes, having some popcorn or a chocolate bar or a slice of pizza once a month or something at your kid's birthday party, that's fine. That gets aggregated into an overall eating pattern, and it's okay. So we're talking about an average lifestyle that's a healthy lifestyle. Whereas Frank said you're getting in, if not 150, 200, 300, 400, at least some mobility in the course. You're doing the best you can to be moving each day. Even if it's as part of your job and you can't get to the gym, taking the stairs or using the elastic bands as part of your chair, walking around, taking breaks, having some weights by your side under your desk, and just making sure that you're mindful of what you're eating. That's called mindfulness. Pausing, if you're at a buffet or you're going out to a restaurant, to pause and think about what you're actually eating. That moment, that hiatus, that pause where you're thinking, you actually can autocorrect and start to eat better. But the answer, getting back, is yes, there's physiology that can make that AM sugar go up. You have to start thinking about what you ate. Marnie would like you to keep a good dietary record. If you're stuck and you want to try to do this on your own, just keep a record. Keep a record of what you're eating. Speak to Janet, get set up with a continuous glucose monitor, and speak to Frank and get set up for exercise program at home. And Frank is developing a way for us to be able to do that with facility. Marnie's available through a lot of different modalities to get good advice. And we can help you achieve this healthy lifestyle, which can absolutely reverse and virtually every chronic disease. There's a lifestyle component. I'll tell you just a little funny story here. Unfortunately, a little embarrassing for me, but nevertheless. So I was giving an interview and I was asked, I think it was Channel 1, it was like in 2015 or so. And they asked me, what percentage of a chronic disease, all human chronic diseases, is caused by lifestyle? The camera on me, I had to come on, I don't know. But you can't say I don't know. So I said 70%. And so I thought 70% was kind of high. Afterwards, people were criticizing me. I was getting all sorts of emails. 70%, that's crazy, you know. Yeah, da, 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 da. So when we wrote this first lifestyle medicine book, of course, I assigned one of the chapters to someone at the NIH, and I said, make sure you have a table in there, a pie chart of what percentage of each chronic disease is caused by lifestyle, so I could get the answer. So it turns out it's actually closer to like 90%. That lifestyle is a driver. You look at lung cancer and chronic obstructive pulmonary, it's tobacco. And you look at liver disease and alcohol, and you look at cardiovascular disease and hypertension, it's salt and it's fat and it's overweight and it's sedentary lifestyle, lack of physical activity. So lifestyle is actually a major driver. There was a study that Dr. Fuster was on by Cara in New England Journal of Medicine, December 2016, taking patients at high genetic risk for heart disease, high genetic risk. Everybody in their family was dying of heart disease. How much of an effect would having a healthy lifestyle have on risk reduction? And it turned out it was like 50%. It was a huge amount that even if you had that genetic hit, that lifestyle can reverse this and correct it. So this is not something that is, from the 1960s and it's a kumbaya, you feel good because everybody's eating healthy and exercising and dancing. This is evidence-based and scientific. You start as early in life as possible, but it's never too late. And it works for preventing dementia and cancers and heart disease and arthritis and osteoporosis and a lot of these chronic diseases. So I think that's really the message that we want to hold on to.
Well, Dr. Mechanick, thank you so much. And looks like we're out of time for tonight.
How did that happen?
I know. It's always a joy to have you as our lead lecturer here. And I always feel a little bit more smarter after hearing you and more aware of everything that is going on with diabetes. We appreciate it and thank you for tonight. I want to remind everybody that after this, the webinar ends, there will be a survey where you can place your comments, questions, concerns. We do have a newsletter with the upcoming webinars that we try to release in a at least 3 weeks in advance so that everyone can prepare and plan for them. So if you want to get those updates in your email and get the newsletter with our calendar for the upcoming month, please provide it in this survey. With that, I wish everyone a good night, and until next time, thank you all.
Great. Thanks, everybody.